Uh, Thank you, Veronique. This is Karuna. I'm going to talk about the impact of a health intervention of an outpatient health insurance product combined with preventive and promotive products in rural India. Next slide. So the intervention first, the NGO that implemented the intervention is Care Foundation. As you know, in India, it's hard to find doctors to go and work in rural areas. So Care Foundation decided to do a hub and spoke telemedicine kind of a model in which there is a community health worker, one per village, who does outpatient care, and she is advised by a shared doctor who resides in the town in a clinic. The community health worker, or a CHW, is low skilled. She is from the village. She doesn't have high education, typically around 10th class, and she is very well known to the community. When a patient comes to visit her, she does the following. She does a basic examination. She gathers symptoms such as temperature, blood pressure, and so on, the basic, standardized protocol. After she gathers the symptoms, she calls a doctor in town using a mobile phone to ask him on for his advice on next steps. Now, the doctor either would recommend her to suggest an over-the-counter drug or to refer the patient to the doctor in town. And if it's an emergency situation, she advises the patient to go directly to a hospital and facilitates the transportation as well. In addition, she also provides preventative advice and sells a suite of preventive and promotive products such as hand sanitizers, mosquito repellents, and so on. Now, she receives about 2 to 3 weeks of training before she can be a community health worker. She's also called the village health champion. Now the charges are pretty modest. It's only 10 rupees or 20 American cents for a consultation while with the community health worker, while it is 24 cents, American cents, is the fee for a visit to the doctor. So the idea of the model is to lower costs of overall primary care delivery by limiting the use of the most expensive resource, which is the doctor in this case. Next slide. The second arm of the intervention is an outpatient insurance product where for $6 premium covers 4 members of the household for a sum assured of 2,500 rupees. So it basically covers buying this health card provides unlimited free visits to the village health champion or the community health worker as well as the doctor if the patient is referred to the doctor by the community health worker. It covers drugs, tests, as well as consultation. And if they are referred to a hospital, then a transportation allowance is provided as well. The important thing to note here is that this is purely a primary care health service. That is, the outpatient insurance does not provide any hospitalization cover. Next slide, please. So the intervention region, this is a rural area of Maharashtra state called Yavatmal. It's a drought-prone area. The development indicators there are pretty modest. As you can see, it's $2 per day per household. That's the income. Educational attainment is fairly low. Only 50% have gone beyond primary school. And they have poor infrastructure, such as only a quarter of the households have tap water on premises. They have to walk fair distance to get to drinking water. They have modest access to toilet facilities as well as basic preventative care such as use of soap and immunization. So some people might say that outpatient insurance can may have an effect only when these basic infrastructure is taken care of. But as we'll see in the results section, that insurance has the ability to add value even when people don't have basic access to basic infrastructure, which may cause them to be chronically ill. As well, since there are not too many physicians available in these villages, in these study villages, the use of quacks or unregistered doctors is very high. And finally, and most importantly, we found in the baseline that the kind of reasons that people go to hospital, right, to get admitted for at least a day, are reasons that people that have access to better quality primary health care won't go for, such as malaria or diarrhea. These are things that are typically taken care of at the primary care level, but in the baseline we found that there's a high incidence of hospitalization for these reasons. Next slide, please. So I'm going to get to the results now, but I'm going to take a second to describe the experimental design. So this study, this impact evaluation study, used a randomized control trial. So what we did was we had 30 villages in Yavatmal district. In each of these 30 villages, we randomly identified 30 study participants. Now there's 3 groups. The first group, treatment group 1, received a substantial discount. They got a little voucher that gave them a substantial discount, and they had the option to purchase the outpatient insurance health card from the village health champion, as well as the respondent received a substantial discount on any preventive and promotive products that the village health champion sold, such as soaps and mosquito repellents. So that's treatment group 1. Treatment group 2 received a hefty discount on only the outpatient insurance product, while the last group, the control group, had access to the community health worker, but she did not receive a big discount on the health insurance. Instead, she got one free visit, a pass that gave her one free visit to the community health worker, so that she was familiar with the service and could choose to purchase the health card if they saw it fit. So the idea now is we did a baseline and then an endline survey, and we would like to compare. We compared the outcomes of the treatment group 1 and the treatment group 2 with the control group, so that we can find out what is the independent impact of a person having an outpatient health insurance card, as well as the preventive and promotive products, and compare it to people who had not higher access to the outpatient health card, but had to pay a modest fee per visit each time they visited the community health worker. So all these, so the important thing to summarize again is that we are comparing people with insurance to people without insurance, but still have access to service through a modest fee for each visit. So we found 3 interesting results. The first one is that having outpatient insurance substantially increases visits to the village health champion. Both the treatment groups were visiting 10 times more the village health champion compared to the control group, where who had to pay for each visit. As well, they were using other providers as well, and we found that their share of the village health champion to total provider visits was also substantially higher at 7% in the treatment groups compared to the control group, which, as you can see, is pretty small. There was some evidence that people used other providers largely because they must have been quacks. They decreased use of that in the control group, again in the treatment group compared to the control group. We didn't, through qualitative studies and interviews, we concluded that this higher use of the village health champion does not represent needless visits, but they were visits only when medical health attention was called for. Next slide, please. So the second finding is that the village health champion refers the patient. She typically handles 75% of the cases by herself, and 25% of them the doctor advises that she refer the patient to himself in town because the symptoms mandated that. So we found that people with a health card, they come to the community health worker more, but they also get referred more. So on average, it was about 0.45 referrals in the treatment group over the period of 6 months compared to 0.24 in the control group, almost twice as higher. Our signal finding is really that although hospitalization cover is not included in this product, we find that the treatment group too, they spent 550 rupees, about $10, $11 less on hospitalization expenses a year after they had access to the outpatient insurance card, although there is no hospitalization cover. Next slide, please. So the conclusion is that we find that a prepaid health card has substantial social benefits in terms of higher treatment-seeking behavior and improvements in health outcomes compared to a pay-per-use model. The policy implication is that, at least in India, there's always been a bigger emphasis on hospitalization cover when it comes to large insurance schemes. So the implication here is that both insurers as well as governments that provide inpatient insurance products could consider throwing in primary care, because this evidence suggests that whatever they had spent on outpatient cover may be offset by lower claims by diseases being stopped in the primary care level and without getting exacerbated and causing the patient to go to a hospital, thereby leading to lower claims ratio. And as well, people that are not very savvy with insurance, they are not satisfied if they don't claim, such as an inpatient product. If they don't claim, they are unlikely to renew. So instead, if they use the primary care component, they are more likely to renew and view the product favorably. That's it from me. Thanks a lot.
Thank you very much. I think it's very interesting to see when we talk about uptake of microinsurance and see what the impact is, to see this interplay with servicing and change of behaviors. And I'm sure we'll discuss it a bit further in the Q&A session. Now I'm very pleased to introduce our last speaker, Howard White, Executive Director from TreeAI. He will talk about way forward for more and better evaluations microinsurance.
Okay, thank you very much. And I'm very happy to have the opportunity to speak at this webinar. We've had some very good presentations explaining what impact evaluation is, and I hope that the participants are all having a good understanding of why impact evaluation is important. There's been a big drive to results in recent years, and too many organizations still confuse simply monitoring outcomes, seeing what's happening in project areas, with results. But it's not the same thing. If by results you mean what your agency has achieved, then you really need to do some analysis of attribution, of what difference your program made, which is how Ralph defined impact in his opening remarks. And it's serving that purpose for this community which this book is intended. So I'm just going to make 5 points which do overlap somewhat with some of the previous speakers about how to ensure you do good impact evaluations which are of good quality and are of use to you as program managers and policy makers in designing and implementing your programs in future. And perhaps surprisingly, my first rule on doing good impact evaluations is to not always do impact evaluations. Often we see people rushing to do an impact evaluation when actually the intervention is not really ready for it. And so at 3IE, where we fund impact evaluations, we've in fact funded studies which probably shouldn't have been done. And they shouldn't have been done either because they were using some technology which turned out to be faulty, or they were promoting an intervention which really no one wanted. The take-up was very low. And that's frequently a problem with microinsurance products, and that might be a problem that might be solved by better marketing, better promotional understanding of insurance products. but it might be that the product really is unsuitable for the intended target population. So rather than doing a large-scale impact evaluation, which can cost $500,000 or more, of a project which is based on faulty technology or an intervention design that no one really wants, it's best to have a formative research stage where you test these basic things before you go to a larger scale impact evaluation. In clinical trials, where there's a much stronger track record of doing randomized controlled trials and other forms of evaluation of effectiveness, this is precisely what is done. Once a medicine is judged safe on the basis of animal testing, they do what's called first-in-human trials, where it's just tried on a few people to see if there are many severe adverse effects. Then it's done on a smaller scale to basically see if the thing can be done, people actually take it properly and so on, so adherence to the protocol. Then an efficacy trial is done, which is again fairly small scale, before going to a larger scale effectiveness trial. So it's learning in steps rather than with a new type of program going straight to a larger scale impact evaluation. Second point is to use the theory of change to inform the evaluation design, including data collection. So with an insurance product, you do want to understand people's understanding of how insurance works. There is this problem that was mentioned in the last presentation about dropout after the first year because people didn't receive any payouts, so just themselves paying in premiums, not getting a payout, so they think it's not worth anything, not worth paying, so they then discontinue the product. With a better understanding of insurance, then they may not do that. And so you need to be testing the causal chain along the way to see why the product is working or not. And that requires different types of evidence that you're collecting, not just the counterfactual evidence of comparing treatment and comparison groups, but also other factual evidence from both quantitative and qualitative data sources. So a good mixed method design that allows you to understand the causal chain is very important. Third, and this was mentioned also, is the importance of getting the sample size right. Too many impact evaluations have too small a sample size, and that matters because what power means the ability to be able to detect that a program's working if it actually is working. And when we do our power calculations, we aim normally for a power of around 80% in social interventions, economic interventions. 80% means that if the intervention is working, 80% of the time we'll find that actually yes, it is working. That means actually in 20% of the time when it's working, we find it's not working, which is not a good thing to find. But actually in reality, the power of study is often less than that. It's often only around 50%. So half the time when the intervention is working, we actually find it's not working. There's it's not an evidence of impact. And that's not a good place to be in. So you really need to do power calculations before you start your study to find the sample size you need and to not go ahead with the study if you can't have it sufficiently powered with a sufficiently large sample. Do something else instead. As the fourth point, randomization, which is spoken about by the second speaker, Demoko. Randomization is good, and if you can do randomization, then probably that's the route you should be taking. And microinsurance is very amenable to randomization. You can randomize by having vouchers to offer differential premiums or subsidized premiums to look at willingness to pay. You can randomize across different designs of the intervention with different information packages, various ways in which you can randomize to improve the design and learn about improved designs of delivering insurance, and of course looking at the impact on the outcomes of interest. So microinsurance is very amenable to randomization, but when you're doing a randomized control trial, do always have a plan B, because it often happens that the integrity of the randomization cannot be preserved because maybe the implementing agency goes ahead and in the end rolls out the program in a non-random manner, and so you have to have a plan B that allows you to do the impact evaluation regardless of whether there was random assignment or not. And finally, as was actually mentioned at the end by the last speaker as well, sorry, the previous speaker, Divya, to always make sure you're engaging key stakeholders from the outset. You need to engage policymakers and program managers from the outset, because in the end, we're not doing impact evaluations to publish nice reports or publish academic papers. We're doing impact evaluations so we can learn what make better programs, to implement more effective programs, and so on improve lives. And if we don't engage key stakeholders in the evaluations from the start, in helping set the evaluation questions, making them aware of the evaluation and why it's important, and having a feedback loop on findings as they emerge, then we won't succeed in having that policy influence. And that's why we're doing what we're doing, so we should never lose sight of that. Thank you.
Thank you, Howard. Thank you very much for this very interesting last presentation, and I will send you the first question we got, and I think it kind of fits rather well with regard to the point you made of the costs and the energy needed for impact evaluation. So one suggestion was like, how is it possible to maybe assess the applicability of findings from one study to another setting, and what can be considered here?
Okay, Veronique, that's a very good point, because it's very dangerous to try and generalize from one setting, from one study, to have a global policy and say something does or doesn't work based on a single study. That doesn't mean that we can never try and generalize, and I think the way we can generalize is by particularly having a good theory of change that helps understand the study context. And so if you see, I think you can look for generalizable conclusions about, for example, the risk aversity that poor people have, and so how insurance might help them overcome risk aversity, but actually there's a level below which people live where that's not going to happen, and it will be somewhat better off households, and the productive insurance, agricultural insurance, are more likely to take part in that assurance. That would be a lesson you think of something you would generalize from to carry to another context, but then try and interpret that message in your context. More specifically, I would say, you don't want to really generalize based on single studies. You do want to try and generalize on a body of evidence, and there is a technique called systematic reviews. Indeed, there's a chapter in the book on this I contributed, which draws together evidence from a range of studies to help you get firmer policy conclusions and findings based on a broad range of evidence. So I would strongly urge funding agencies and implementing agencies to be looking towards systematic reviews, as many agencies are now doing, as a stronger source of evidence.
Great, thank you very much. I would like to pass over a question to Karuna with regard to the health insurance case study. I don't know, one question was, did you look at across the range of products, and with regard to that, would it be possible to link the tips and issues raised and broaden it up a bit? Let me see, Karuna, I need to unmute you. There you are.
Sorry, could you repeat the question?
So did you look in the case study also at other products, and would you have similar tips and issues raised in those products, or did you look solely at health?
Yeah, so the intervention here was only health, specifically outpatient insurance, as well as a suite of preventive products such as soaps and mosquito repellents and so on. So the whatever impact we found, I have presented in my presentation. So we didn't look at any other interventions, if that's what you mean.
Yes, exactly. Yeah. But I think if it was just a question for this case study, if you looked at other products, we do have another question for you as well, which is more specific. It's very much like, did you look at the cost of a medical visit, and which part was unsubsidized and which part was subsidized?
Yes, that's a good question. So this was a pilot project which we wanted to evaluate to see if it look at the client value. In terms of the business case, this 300 rupees for a for the outpatient insurance product is subsidized. It does not cover their costs. The true cost per customer is closer to 600 rupees or twice the actual premium for the outpatient product. So yes, 600 rupees is the true value. But our intent here was to demonstrate the client value. CARE Foundation subsequently has been taking steps to improve the business case for itself.
Great, thank you very much for those clarification. I would like to move on with a question for Divya with regard to impact evaluations and of course the limitations. Often that donor-funded interventions were pilots and were also kind of within a project timeline. The questions to you particular would be, what strategies can donors use to do some level of impact evaluation with programs that may still be young and require changes along the way?
So that's a good question. To some extent, Howard also spoke about this. So the first issue would be to have a plan for an impact evaluation. So it's always a good idea to have a baseline, and then the program should be in some form that it's working properly before it can be evaluated. So if you can have mixed methods, which is a very good strategy. So having qualitative interviews and depending on qualitative interviews with stakeholders, with community, with healthcare providers, if it's a health insurance, or with other stakeholders is a good idea. Also to realize what things are working and what are not working. Looking at the quantitative impact should really rely on when the program is doing well and you know that it will take off. So initially qualitative interviews would be a good way to go about.
Mm-hmm. Thank you very much. Moving on, Tomoko, you were talking about randomized evaluations, and we got a couple of questions in with regard to acknowledging that of course every country is different, but what would be your guess estimates on timing and costs, but also what can one do when one has no time to implement an RCT? Would you recommend any other statistical methods that could be applied more readily?
Okay, thanks. So I'll start with the second question. So there are many circumstances where randomization isn't possible or an option. Then I think the first thing you want to think about is whether you can find an appropriate comparison group in some other way, this alternative counterfactual world. I think that if you have existing large data sets from the program sites and from the country, I think there are many different ways. Statistical methods, I can't go into details, but to create this counterfactual world exposed. This is of course not ideal, but I think that's the second best that you might want to think about. Secondly, I think in the situation where randomization is just not possible, you might not have enough sample size, you just don't have time. I think one option always you have is to do some exploratory research, either qualitative, doing interviews or some small surveys to try to understand the potential impact mechanisms. And I think, Karuna talked about all the impact mechanisms of the community health insurance program in India. I think trying to understand that potential impact mechanisms could help you, even design the next evaluation when you have time and resources. Going back to the first question about the cost and sample size, so this is a very difficult question. People often ask me, here's the program design, and this is how we want to implement the program. Tell me what the sample size we would need to rigorously evaluate impact. And it depends on so many things. It depends on how the program is being introduced, what you think the effect size is going to be. It depends on how often you can collect the data, and how noisy, how much variance the outcomes would have. So the cost of our cities varies really from $50,000 to $500,000. So it's very difficult for me to actually tell you the appropriate cost. You need to think about a lot of different aspects of the program.
Thank you. And you also replied, another question we have was with regard what would be an appropriate sample size. I know it's sometimes difficult because easy questions in this area require a bit more subtlety, and of course it's always very context specific. But thanks you very much for an attempt to making this clear. We do have a lot of questions, so what we try to do is to address them in writing after this call, but we are coming to the end, and I would like just to share one more question with Ralph, and I would like to ask him, I think we got a couple of questions in that direction, is like how to make sure that these impact results are being taken up. Howard also addressed this. Do we know already results? Do we know impact assessments which were taken up, and how were they used effectively? Ralph.
I think the point has been made before. It's important to work very closely with the stakeholders so that actually the insights which are being gained in the evaluation are being fed back into the program. I mean, sometimes evaluations are made in these project cycles of 3 years, and the next one is being planned. I mean, ideally, they take place when there is an intention to actually go into the next phase, and then the information can be taken on board by supporters, funders of a specific project. And I think this willingness to learn is crucial. I do think there have been examples of organizations looking at what has been learned in certain places, be it, about also the positive appreciation of value-added services in health insurance, and trying to come up with something which people might appreciate more and which actually give them better guidance. And I do think they find their way into program designs which might be even beyond the context in which a specific finding has been made. But it would be to verify that would unfold the same positive effect in such a context as well.
I think we can really take this as a takeaway from this discussion, is that, of course, thinking about impact, it's kind of like an after the intervention, but that it's really extremely important from the start off, from the design phase on, look at what impact or evaluations should be introduced, figure them from the start, have a dialogue with the policymakers to make sure that it's not just a result at the very end, but it's a process which is important. And again, also with regards to some of the comments made, it's not an end result, it should inform further interventions. So again, we need to make sure to really get the lessons learned out, and I'm so glad to see this framework coming to life now and being shared, because I think we need to kind of consolidate the space to make sure that the different case studies talk to each other and inform each other. I would like to end here with a big thank you again to Ralph and Katja for really being behind this book and really making it happen. Also all the authors who participated in the book, and also especially those who were participating today at the webinar. We will get back to the remaining questions in writing. Also, thank you for all those who sent in questions and all those who listened in. We would like to give you now 3 short questions which are important for us, not only for the book and the authors, but for further webinars, as we are talking about lessons learned and improvement. So please do take 2 more minutes to apply yourself to the following questions. So the first one being, I found this webinar informative and stimulating. So you have until 5, click intuitively, strongly agree to, I don't know. So I close it. And results are, I agree, 77%. That's really good to know, and we definitely will move along in this direction. I will move on to the second question. Which is, I believe impact evaluation should become a mandatory component of any microinsurance program. This goes back to the point we just made also with Ralph and Howard and also all the other speakers. It's crucial to look at impact evaluation from the start, and it should be mandatory to each microinsurance program. You have one more second. And agree, 41%. I see we still need to have some convincing to do, Ralph. So I think we definitely are going to talk more about the importance of impact evaluations. And we can move on to the last question. I intend to recommend the book A Practical Guide to Impact Evaluation in Microinsurance to at least one of my co-workers. So you have this option to say yes or no, or you don't know yet. One more second. And we are going to close. Oops. 71% intend to share the book. This is for me then a good opportunity to say again that the 10 winners of the book will be notified per email after this webinar. The book will be available end of May. You can also request it, but there might be coverage for the postage. Of course, not for the 10 winners. So watch our space. Again, the book will be available end of this month in print. You can already go to our website where you can access the individual chapters individually. Again, thank you very much, and I wish you a great morning, afternoon, or evening, wherever you are. Goodbye.